Good afternoon, class. My name is John Carson. I'm going to do my health education at the level of primary care presentation for Vacaville, California for nursing 445. Just to give you a little background, Vacaville was chosen as my low-income community to where I would do some work. Give you some demographics and an introduction. Two educations, one on diabetes and one on unhealthy eating patterns or nutrition and health. Based on the data and my interviews, the community of concern had rates of mortality and ED visits and hospitalizations due to diabetes that exceeded national benchmarks. ED visits due to diabetes in this zip code, 604.9 visits per 10,000, well over the standard. And then for the unhealthy eating, demographic data and interviews, the community of concern lives a sedentary lifestyle, and many of the residents live below the poverty line and have chosen between expensive produce and cheap, affordable processed food. All the key stakeholders I interviewed identified that healthy eating habits are not taught in local schools or community centers. Background and significance. Diabetes in Vacaville's adult incidence is 9.65%, when the California average is around 7.75%. So Vacaville is well above the average for the incidence rate of diabetes. There's found to be a lack of education, a lack of access to healthcare, and lack of affordable health food within the area. For the unhealthy eating patterns, nutrition, for Vacaville, California, 36.5% of the population is obese, almost greater than 1 in 3. There's a high consumption of fatty foods or fast foods, and 10% or more of the population is below the national poverty line. Looking at California averages for obesity, the statewide average is 24.2. So in both areas, diabetes and unhealthy eating patterns associated with obesity, Vacaville is well above. So these are my two targets. In correlation with Healthy People 2020 objectives for diabetes, objective goal, one of them is to reduce the disease burden of diabetes and improve the quality of life for all persons who have or are at risk for diabetes mellitus. Interventions include A1C control or improvement, education and access. And then for 2020 objectives for nutrition and health status, the goal is to promote health, reduce chronic disease risk through the consumption of healthful diets, and achievement and maintenance of healthy body weights. And interventions are dietary guidelines, school intervention, and early education. The needs assessment. For Vacaville, the population stakeholder was Julie R. As a local resident and a primary care nurse in a local community clinic that serves the community. She stated that Vacaville is a thriving city, but without its own faults. Smoking is a big deal. The issues of drug use is as well. And say that she has a big Hispanic population that suffers from diabetes and hypertension. A key stakeholder for Vacaville was Gary P., CEO of North Bay Health Systems, a local private hospital in Solano County, 3 clinics, over 30 primary care physicians. He also stated that Solano County, which is part of Vacaville, is an underserved community. Vacaville needs are to control the obesity and diabetics and increase the mental health services within the area. These are all taken by my windshield survey through the drive, and also a local needs assessment performed by Kaiser Permanente and North Bay Healthcare. The theoretical framework needs assessment. Throughout this quarter, we used the precede, proceed model. It's a comprehensive structure for assessing health needs, for designing, implementing, and evaluating health promotion and other public health programs to meet those needs. Use Using this model helped in the development of population community-based education and interventions that will meet the personal needs identified through personal observation and key stakeholder interviews. It's really helped me to look at the behavior of the community that I was going through and really set up the framework for really good intervention for both the diabetic population and teaching about nutrition. Issues. There are some population barriers identified. A lack of education, lack of knowledge regarding care options available to them within the community. Support was a big barrier. Low socioeconomic status is always a barrier. And high percentage of processed food consumption within the area. There's almost a fast food joint on every corner, if not multiple ones. The great thing about these barriers here is the clinic that I volunteered at has the appropriate resources to help combat these barriers. But at this point, they're not well integrated into the primary care setting. They're kind of subunits working right alongside each other, but not together. I implemented community-based education at an appropriate reading level for the patients. Now, on average, the adult learner has a reading level between that of 7th and 8th grade. Due to that fact, all my material, I performed a readability score to make sure that it was appropriate for the population that I was intervening. Issues continued, creating change. Change is needed in order for the population to decrease their undesired health outcomes. Needs and needed behaviors, self-efficacy, the want and desire to change, some kind of support system, and education that's appropriate and culturally sensitive. Issues continued with education and practice. I chose the learning theory of constructivism, which states that learning as a process in which the learner actively constructs or builds new ideas or concepts. Participants enjoy the mutual engagement and lack of hierarchy associated with active learning. I chose this due to the site that I picked. I couldn't really hold a private class for the participants due to time constraints and feasibility. So I was actually in the clinic during clinic hours and was able to meet with patients that really wanted to talk about what I was educating on. I was hoping for more foot traffic, but I did get quite a few participants that would listen and take the after quiz for the feedback. The intervention. The Vacaville community has a high percent of diabetics. Demographic data and interviews. As stated before, the community has concerns of the high rates of mortality and ED visits associated with diabetes and hypertension. So I had a couple of flyers that were there that patients could take that kind of quickly reiterated some of the education points that I made to them that day. If they were diabetic, one of the main key points was letting them understand that they needed to get routine blood tests to make sure that they are controlling their diabetes well. A quick A1C test, a lot of them didn't know what that was, so I explained to them what it was and the importance of it and how it's a true indicator of how well they're controlling as opposed to just their daily sugars. For the nutrition aspect, just like Healthy People 2020, going over dietary guidelines and improving weight status, I really wanted people to take a look at the nutrition food label and be able to assess it well and know what they're actually taking in when they're reading it, especially the serving size here. I wish I had a picture of it, but when you eat a bagel, that's just not one serving size, that's more like 4. So it's important that a lot of people know that you need to start looking at your serving size and then go down to your calories and your list of macronutrients. It was a big eye-opener for a lot of patients that I saw. For the implementation, I didn't want to overwhelm the patients with data and statistics. Instead, I went and narrowed my focus to give general information on what diabetes is, how medication and lifestyle changes can help them maintain their sugars. I did the same thing here, nutrition, offered healthy options. It really kind of became more of a one-on-one with a lot of these patients as opposed to multiple ones. I really felt that I was giving good education and meeting the needs of the population, because when it's simple terms on one-on-one as opposed to multiple groups, you can be a little more culturally sensitive. You can really listen and get great feedback from the people that you're educating. My budget included costs accumulated over the quarter, as well as future needs to meet the needs of the assessed population. Personal budget education was done for free and on my own time. So it equate time and gas to be around $300 for this project. Materials, $15 in paper and ink for printouts. The company, North Bay Healthcare Centers for Primary Care, which was gracious enough to let me do my volunteer hours there. For this project, I would say 3 hours of shadowing with a clinical advisor, about $225, plus an additional 3 hours of me interviewing diabetic educators and staff dietitians. Future budget, when talking to key stakeholders, they were aware of my findings that there needs to be more staff and new culturally sensitive material. Estimated yearly cost or investment for either a new physician to help with the weight load, or a diabetic educator perhaps, and more staffing such as medical assistants and registration, about $500,000 there for the budget. And then going back to my interventions, another big piece that was very helpful besides this education, if you go back to the Healthy People 2020, and one of my main objectives is access and educational resources, is that the patients that go to this clinic have access to the company's dietitians and diabetic educators. A lot of it didn't know this, and so the diabetic educator was actually on site that day and was taking appointments. So for the patients that wanted more information, either being newly diagnosed or maybe living with this disease for years, found out that they had a really awesome resource that they could actually utilize with their healthcare plan and at the clinic with a minimal wait time. Both the patient and the educator were very excited about this part of the intervention because they wanted to see more patients and they wanted to make a bigger footprint in this community. Same goes for the dietitian. Though limited in resources, they do have openings and do take patients on a case-by-case basis, which is very helpful for both those that are suffering from, say, hypertension and obesity, and also as well as the diabetics can go through that as well. So we've gone over my budget. We've gone to the intervention page a few times for you because I've missed a few things. Project evaluation and outcome measurements. For diabetes, this is listed in my proceed portion of this quarter. The process objectives is that I wanted the material at appropriate reading level. And while I'm doing it and building this, did my material capture the attention of the readers? And does the after quiz allow for proper data collection and outcome results? My impact objectives. Were the participants engaged during this? Can the participants relate to the material? Are they scoring well on the quiz, and do they have follow-up questions for me, meaning that there's true engagement there? I do believe that for the majority of the patients that I did see, they were engaged. They could relate to the material, and so far, preliminary scores, they're doing pretty well on the quiz they handed out. Short-term goals for this is that 60% of the participants would state they learned something new about diabetes management. Minimum 50% of the participants would score 80% or higher on the post-education quiz. And 90% of the participants would be able to identify 3 local resources for education and follow-up care. And all participants will be able to state what a health A1C level is. I'd have to say out of the last 2, so far they're doing really well. There's lots of resources available to them, and I had like to educate them on those. And as I stated before in part of my intervention, a lot of them were able to secure appointments with either a diabetic educator or a dietitian. All participants were able to state or at least point to the paper and hand out what a healthy A1C level is for them as a diabetic. Nutrition and healthy eating habits. Process objectives while doing this was also making a good readability score. Did the material, can it catch the attention of the readers? I tried to make it bright and simple in terms, not overwhelm them with a lot of writing in a big pamphlet full of small font, trying to get everything I can on there. Really wanted to pinpoint and narrow the education that I provided. Does the quiz reflect proper data collection? The impact objectives here were pretty much the same for the top. I really wanted patient engagement, relatability to the material, good scores on the quiz, and follow-up questions for more feedback and more dialogue between me and the patient through education. Wanted 80% of the participants to be able to correctly identify the serving size on a food label, or a short-term goal. 60% of the participants to be able to identify 3 macronutrients, the protein, sugar, and fat, found on the food label. And that all participants would be able to list 3 healthy food options. And they would be able to identify primary resources available to them in the primary center, which all were able to do that. And as I stated before, some also got an appointment with a dietitian. Results and conclusions. Strengths: had a great mentor, a very interactive facility. Weaknesses: the time frame. I don't really think there's enough time. The facility parameters were pretty hard. Kind of last minute, I was able to get and secure this one here. I believe a full semester would have been better for a big production, more planning, and a better piece of the education. I think would have been a lot better, more thorough. Problems encountered: low foot traffic. Saw maybe 10 to 15 patients. I would have liked to see more, but given the time constraints and patient constraints, they're already there an hour for an appointment. To stay there an extra 15, 20 minutes with me is kind of a lot to ask, but the ones that did were very thankful and thought the time there was beneficial. So that concludes my health education piece for this semester. I hope that you guys liked it. Just a quick overview is we'll go back to EVO 2020 objectives. My main point in intervention was educating about A1C control improvement for the diabetics and for nutrition and health status. So my main intervention was dietary guidelines and early education by teaching them how to read their food label, and also guide them to a local dietitian and online resources such as the government resource and the food pyramid that kind of help them and guide them with readable material on a daily basis, and early education on good food and healthy options for them and their families. Here are my references, and that concludes my presentation. Thank you for listening.